further delay, I would like to call upon Dr. Muridhar Sharma sir, STMCA would be to take over the session. Welcome to you, sir.
Okay. Next is about the Ashmari. अथातो अश्मरीणां व्याख्यास्यामः यथोवत् भगवान् धन्वन्तरी चतस्रो अश्मर्यं भवन्ति श्लेष्माधिष्ठानः तद्यथा श्लेष्मणा वातेन पित्तेन शुक्रेण चेति. Now Ashmaris are classified into four categories: Kapada, Vatada, Pittada and Shukrada. तत्र असंशोधनशीलस्य अपथ्यकारिणः प्रकुपितः श्लेष्मा मूतसम्पृक्तो अनुप्रविश्य बस्तिम् अश्मरीं जनयति. The etiology of Ashmari mentioned in Sushruta is one is because the persons do not have the habit of having the shodhana, Rutucharya. In the Rutucharya, you have seasonal Shodhana Kriya, and if anybody doesn't follow that Shodhana Kriya, it's one of the important causes for the Ashmari formation, stone formation. Apathyakarinaham, those who do not follow the diet restrictions also, they tend to have the involvement of the kapha, that the slimy portion, which gets into the urine and then it results in the ashmari. So according to Shuddha, the primary reason for the stone formation is a presence of relatively insoluble substances like the slimy substance, maybe the protein and so on, which can result in condensing into the stone formation. Now, about the theory of the stone formation and so on, we will discuss again. So, the refers to this issue at the end, and there again we will have more of discussion about this issue. Yeah, so, Ashmari also is considered as a Mahavyadhi, and the incidence of the Ashmari stones, urinary stones, is now quite increasing, and particularly in the eastern countries, in India also, is considered to be one of the country areas where the incidence of the urinary stones is quite high. The incidence of uric acid is quite high in the Asian continent, and the reasons, of course, we will come to that reason part later. In India also, the areas, zones where the Ashmari stones are more common are in the northern part of the country. These are what we call as the stone belts. Now, reason for this is considered to be presence of some salts in the water. The water sources could be one of the major sources. Majority of these areas there will be salty water conditions, and hence it is considered to be one of the causes. Then the other causes and the other incidents, that part we will discuss later on. Now, in the present day situation, the urinary stones are classified into mainly two categories: radio-opaque and radiolucent from the practical clinical point of view. Radiolucent are always the stones which do not have the calcium, whereas the radio-opaque stones have the calcium contents. Now, radiolucent stones, the most common is the uric acid stones, and the causes for that would be the increased uric acid secretion in the urine, and consumption of excess of protein is considered to be cause. And uric acid stones are usually soft in consistency and relatively greenish in color. Whereas the radio-opaque stones, they are again categorized into three categories: hard stones, soft stones, and cystine stones. Cystine stones are, though do not they have the calcium content, they would be opaque to the X-rays, and they are usually produced due to a metabolic abnormality of the cystine metabolism. Cystine is one of the amino acid substance, and the suet stones are the stones which are produced after a consequence of urinary infection, where as a result of the infection, some solid substances, semi-solid or solid substances, they get settled in the urinary tract, and that acts as needles for the stone formation. So there could be a crystallization occurring over some needles, or needles is some solid substance over which the solvents they tend to get crystallized. Again, a bit more of that, we will come to that part when we discuss about the etiology later part. Now, or the suet stones also could occur as a result of the damage to the mucous membrane of the urinary tract. If it becomes rough, there could be crystallization. But all these stones, they constitute only about 80% of the total radio-opaque stones. Now, out of the 100 radiolucent stones are only 10%. 90% of the stones are radio-opaque. So, a plain X-ray will be good enough to make out the diagnosis of stones as such. Among the hard stones or calcium containing stones, the major categories are which constitutes about 80%. The causes could be hypercalciuria, where the total amount of the calcium content in the body is increased, and it could be result in due to high protein intake, high salt intake which contains calcium, or abnormality of the parathyroid hormone. A parathyroid hormone is the major hormone which regulates the calcium, this one, metabolism in the body. Consumption of the calcium orally. Now this has become a fashion now. To consume calcium contents as considered to be one of the very common prescriptions in the after the middle age, particularly in women, and it has become a fad, right? And that also could be a cause for the increased incidence of the stone. About the increasing incidences and so on, a bit more of that, we will come to that part later. Then the hyperoxaluria, abnormality of the oxalate metabolism, it also can occur due to or it can also result in the stone formation. And one of the important sources of the oxalates is the food sources. Many of the food substances, again I'll come to that part, which of the food substances would increase the oxalate content, particularly green vegetables or tomato-like substances which contain more of oxalate contents. They are also known to induce the hyperoxaluria and then the oxalate stones take of that. So dietary factors constitutes one of the important causes. Then some of the people may have a genetic abnormality of overproduction of the oxalates in the intestines during the digestion. It's a very few genetic abnormality. Low calcium intake, consumption of low calcium also could be a cause for more of oxalate secretion in the urine, and it can result in an abnormality of the injection, like consumption of the ethylene glycol. Ethylene glycol is a very commonly used preservative in many of the medicines, particularly cough syrups or many other liquid syrups which are available in the market. Ethylene glycol is very commonly used as a preservative, and that also could be a cause for the oxalate stones. And the solubility of the urine. Now, the other theory of the stone formation. Currently, you have mainly three theories for the stone formation. The one theory is Vanitas, where there is some solid substance in a solvent, and the solute tends to get crystallized over it. The other is the concentration, hyper concentration theory, where the concentration of the solvents are more, and that can result in the stone formation or crystallization. Now, this can occur due to a low urine volume, as occurs in case of summer, or patients who have the citrate content in the urine could be, if at all it is lesser. See, citrate content is necessary to keep the solutes, particularly calcium content, could be in a soluble form. Calcium citrate is relatively soluble. If it is lesser, it can result in the stone formation, or renal pathologies, where they again the same thing can occur, where the concentration of the urine would be more, and it can result in the same stone formation, or the protein intake also can be a cause for the stone formation. Now, hence, the total causes of the stone formation could be categorized as the lifestyle and diet, climate, and occupation, which can result in the stone formation, or the factors which promote are consumption of the salt substances, calcium, and then if more acidic substances like ethylene glycol are consumed, genetic, of course, they can and are one factors. Then the environmental factors, the epigenetics also, they also can occur one of the factors. And then the citrate and magnesium are the inhibitors for the stone formation. They will prevent the stone formation if they are lesser. The concentration of the citrate and magnesium in the body is lesser, that can result in the stone formation further. And the stones are now identified based upon the crystals. Now, all this prelude is necessary to make out the later on Vataja, Pittaja, Kapaja, Ashmaris. When you look at the urine, examine the urine under microscope, usually the stone crystals could be seen, and that would help you to identify the stone formation, type of the stone, many times by simple examination of the urine. Of course, the other way of confirming would be when a stone is manually removed or it is expelled out, it can be examined by the chemical examination. But anyway, from the practical point of view, this could be enough for the simple assessment. When you go for the microscopic examination, the oxide, calcium oxide crystals will be seen as a multi-angled or multi-dimensional diamond-shaped crystals. Phosphate crystals are seen as a simple rod-like which will be clubbed together, mass of a rod-like substance. Uric acid crystals are flat and somewhat rectangular as such, flat these lamellar-like stone are seen. Straight stones usually present with the exact some hexagonal shapes and the surface will be flatter. Whereas the cystine stones, they will be irregular masses, irregular substances, and this way is one of the measure of identifying the stone formation. Like now, that's about the basic introduction to the stone, which will help you to make out what Sushruta has mentioned. Now, tasam pururupani jwaraha basti peda rochakau mutra krichram basti shuro mushka shepatam vedana krichravasadha bastaganditvam mutra seti ythastho vedana varnam dustam sandram athavidam pururupe ashman krichrad mutram srijati manavaha. The Pururupa, prodromal symptoms according to Sushruta are the jwara, that's fever, bastipira pain in the urinary tract area, or bastishiro mushka sepasham vedana, the pain in the genital area as such, or kritravasada, difficulty in expelling the urine or urinary these difficulties. These are usually the clinical signs of what we call as infection. Patients who have a infection, it can result in these symptoms. And we now consider infections as either a cause of the stone formation or also can be a result or consequence of the stone formation. It's true for both the point of view. Sushruta has categorized these symptoms as the Pururupa. Then Mutrakritram Bastaganditvam Mutrasya, the urine having more ammoniacal smell. Bastaganditva is a ammoniacal smell. More concentrated urine will have the smell of that ammonia-like substances. Basta is the goat's urine. Goat's urine is hyper concentrated and it will have very high smell as such. And Mutratricha, the total quantity of the urine could be lesser or difficulty in the maturation, which could be due to the hyper concentration or the mechanical movement of the stones in the urinary tract. That could be pain. That is the clinical symptoms. Or it could be yathasu vedana varna. The color of the urine could be altered depending upon the type of the stone formation, and the specific gravity of the urine also tends to be increased. Avilam, Sandram and Avila. It could be looking like some turbid water. The turbidity of the urine could be increased. Density, specific gravity also could be increased in case of the Pururupa. Atha jatas, once the stones are formed, then the clinical symptoms would be Nabhi Basti Sevana Mehaneshu Anyaramasmin Mehato Vedana. Typically, what we call as a urinary colic. Now, a colicky pain in a stone formation is always suggestive of a stone which tends to move. When the stone moves in the urinary tract, there will be colicky pain, and the colicky pain is characteristically acute and sudden, and it will have a characteristic reference points. Renal pain would be referred to the anterior abdominal wall. Ureteric colic will be lying to the groin, and that kind of a pattern is seen, and that's what summarized by Sushruta as a Nabhi. That's suggestive of the umbilical reference, and Basti Sevani Mehaneshu towards the genital area, lying to groin pain also is mentioned as a clinical sign of the stone formation. So stones which tend to move, they will produce a colicky pain, which could be referred to the anterior abdominal wall or from loin to groin, depending upon the location. Then Mehato Vedana, during the micturition there could be pain. That's due to the urinary infections, which could be a complication of the stone formation, or it also could be due to the passage of the crystals in the urine, which can produce the pain. Mutradhara Sandaha, obstruction to the flow of the urine. Now, when I say obstruction to the flow of the urine, It could be if it is a pathology in the urethra. If the stone has blocked the urethra, then obviously Mutradhara Sangha, which could be clinically visible. Elsewhere too, in the proximal area in the ureter or the renal pelvis, if the stone gets blocked, there too it can produce obstruction, but that obstruction will be seen as a hydronephrosis due to the blockade of the stones. There could be backflow, and it can result in the hydronephrosis. So Mutradhara Sangha, I would interpret in both the ways. A urethral stone obviously producing a visible obstruction to the flow of the urine, or the flow could be split, or a hydronephrosis which could be made out by ultrasonography or investigations. So both of them could be considered as Mutadhara Sangaha. Sarudhira Mutrata, Sarudhira Mutrata, hematuria. Now hematuria again could be either visible or occurred. Visible is where the patient can identify the urine, the blood in the urine, or it could be due to, or it could be identified by microscopic examination where the RBC count could be higher. And this is due to the mechanical irritation of the urinary tract, and one of the very common clinical symptom of the stones as such. Mutra Vikiranam, that's again Mutradhara Sangaha and Mutra Vikiranam, they are almost similar issue. Mutra Vikirana is when the flow of the urine through the urethra is split and then it tends to spread. So Vikirana is very typical of the stone in the urethra where it is partially obstructing. Mutradhara Sangaha, where there is a obstruction to the flow of the urine as such. Then Gomedaka Prakasham Matyavilam Sasikalam Visarjati. The urine content would be, urine will be showing abnormal contents depending upon the type of the stones, like either it could be greenish color or maybe very turbid color, or Sasikalam where there could be crystals present in the urine. So abnormality of the content of the urine can be made out as one of the clinical signs of the stone formation. Now, of course, we may make out that abnormality with a microscopic examination or biochemical examination. Dhavana, Langana, Plavana, Prasthayana, Ushna, Adbhagamaniishcha Asya Vedanaha Bhavanti. The pain will be triggered due to rigorous movement of the body. Rigorous movement of the body like running, jumping, or fasting, or maybe the swimming or traveling over the vehicle, so on, so and so forth. A rigorous movement of the body can produce trigger the pain. Now, the most important part is about identification of the type of the stones based upon the clinical appearance. तत्र श्लेष्माश्मरी श्लेष्मलम् अन्नम् अभ्यवहतः अत्यर्थम् उपदीप्य अधः परिवृद्धिं प्राप्य बस्तिमुखम् अधिष्ठाय स्रोतो निरुणन्ति तस्य मूत्रप्रतिघातात् दाल्यते भिद्यते निस्तुद्यते इव बस्तिः गुरुः शीतश्च भवति अश्मरी चात्र श्वेता स्निग्धा महती कुक्कुटाण्डप्रतिकाशा मधुकपुष्पवर्णा वा भवति तां श्लैष्मिकीम् इति विद्यात् श्लैष्मिकी or kaphaja ashmari is produced due to a consumption of kapaja ahara or kapaja ahara vihara, like a reduced exercise. Now, most of the times we will see such stone formation due to the stagnation of the urine. Stagnation of the urine can occur in patients who are bedridden, patients who have a partial blockage of the urinary tract, like prostatic hypertrophy, or any other structural pathology of the urinary tract, like strictures of the urethra and so on. In such patients, the chances of accumulation of the phosphate contents would be more, and the phosphate contents, when they are crystallized, they characteristically they produce the stones of mainly three categories. The three shapes are there. One of these, like when there is a real stagnation of the stones in the stagnation of the urine, and then there is a crystallization of the phosphate, as occurs in case of the bedridden patients or patients with the stricture formation or so on. The phosphate would produce a multilamellar, smooth surface stones, and it is exactly like the Kukutanda. So Susa, when he has mentioned about Kukutanda Pratikasha, that's exactly the same color. And when you take a section of these stones, you will see multiple ring-like appearances, suggest you have that gradual deposition of the stones. That ring-like appearances, cross-section would show that, and they would be having somewhat whitish color, Madhuka Pushpavarna, the Madhuka Pushpa and its color. So this is exact perfect description of a phosphate stone produced in the bladder, produced due to a stagnated urine. Now, phosphate stones also can occur due to more of resolution of the bone and excess of the phosphate content. Persons who have chronic degenerative pathology of the bones, or patients who are bedridden and hence they are not moving the bones at all, which results in the formation of the stones, or patients who are obese and hence they tend to avoid the exercise and hence there is a phosphate excretion. These phosphate stones usually would develop in the proximal portion of the urinary tract, very often in the renal pelvis, and they get deposited and they form a mold of these stones as such, like mold in the sense they will take the shape of that renal pelvis, and they are relatively slightly grayish color. Now, eggs, I think there are two varieties of eggs, whitish in color and grayish in color. Now, these stones, which are produced due to that phosphates and usually in the proximal area, that gray color is added due to the adding of some mucin substances, and some of the eggs also now you will have that grayish color. I think it's imported eggs. So that's also true. Kukurana Pratikasha, it holds to that too. Now, the third variety of the phosphate stones which are produced would be mainly metabolic pathologies, where there is excess of phosphate metabolism, and the phosphate is excreted. It tends to get again accumulated in the proximal portion of the kidney, and it involves renal tubules also. And each renal calyx also would be involved, and they get molded. And this takes the shape of the renal calyx and pelvis, and hence it's also called as staghorn calculus. Majority of the phosphate stones which are produced due to the abnormality of the phosphate metabolism, where excess of phosphate is secreted, and the phosphate metabolism tends to get excreted because of consumption of phosphate contents, and the other kafaja ahara vihara, shleshmala anna as such, it could result in that stone. So, upalepa, there would be accumulation of the phosphate over the mucous membrane, and then it takes the shape, and that's the real staghorn calculus, which we call as the staghorn calculus. Staghorn calculus would be having the same shape as such. Now, characteristically, the phosphate stones, staghorn or the other way, the phosphate stones, because they are relatively bigger in size and they do not move, they do not produce colicky pain. Usually, phosphate stones are initially either painless or there could be mild aching pain, and all the clinical symptoms are produced due to the obstruction, and hence there could be hydronephrosis. Hydronephrosis can result in only a dull pain and then bulging of the kidney tissue, or it can produce the secondary complications like infections, or a phosphate stones also can result in crystalluria. The crystals may be broken down, but colicky pain is generally, now there could be exceptions. In general, colicky pain is absent in case of the phosphate stones. So the Kafaja Ashmari can be easily identified as the phosphate stones as such. The phosphate stones, of course, the causes, it could be, as I told you, it's the same thing. Many times it's idiopathic or hypercalciuria, primary acid. Now that's about the phosphate stones. I think we can stop at that part. Then Pitta Jashmari, Pitta equals to Sleshma, Sanghatam Upagamya, Yathoktam Parividim Prapya, Bastimkam Adhishtaya, Mutra Pratighata, the Ushyate, Chushate, Dakshate, the and पच्यते इव बस्ति उष्णमातश्च भवति अश्मरीता प्रसरक्ता पीतावभासा कृष्णा भल्लातकास्ति प्रतिमा मधुवर्णा वा भवति तां कैतिकीम् इति विद्यात्. Now it's very typical of the steroid stones. Steroid stones are produced as a result of the infection, and patient would have an initial episode of urinary infection due to any reason. Now, source for the infection could be anything, but later on, as the infection results in aciduria, the pH would be lower, and if you are not giving an alkalizer in a patient treating with the being treated with the infection, or it could be due to the abnormality of the mucous membrane, or maybe the abnormality of the pH, that there could be deposition of the crystals, and there will be multiple crystals. Chemically, it will not be having a uniform identity, and hence the shape, the color would be some varying color, usually dark color. Dark grayish color is the urine color. That's exactly what Sushila has mentioned as a Madhuvarna. Or when there is a deposition of the blood pigments. Now, a stone which is present over there can produce irritation and it can result in bleeding, and the blood pigments are stored, it may become blackish in color. That's a Bhallatagasti Pratima. So, Bhallatagasti or Madhuvarna color is very characteristic. Consistency of the stones are usually somewhat softer, not very hard. Surface would be rough passage, so irregular at some areas, as in case of the Bhallatagasti, and the clinical symptoms will be primarily of infection, and later also it can result in a colicky pain because the stones are of varying size. Usually the patient would have a history of a repeated passage of the stones, and hence the colicky pain can be a presentation, or most commonly it is the recurrent urinary infections where the patient would have fever, burning sensation, hematuria, etc. So very obviously the Pictoria ashmari can be identified with the infection induced steroid stones. Now, that are, it also can, the similar symptoms also can occur in uric acid stones also. In the uric acid stones also the symptom will be very much similar, where the patient would be having initially the tendency to have the uric acid abnormality, which could be produced due to consumption of the spicy food, the pitta ahara, and it also can result in a relatively softer stone, and the patients tend to have the abnormalities, exactly the similar clinical symptoms like burning sensation and so on. Incidence wise, steroid stones are more common than the uric acid stones. But of course, in the present day situation, there is a gradual trend to have a increased incidence of uric acid stones also due to the very frequent food habits where the hyperuric acid substances are taken in. So, and uric acid stones also can result in the same issue, like urinary pH could be reduced. So, in any case of conditions where there is aciduria, it could be either fluoride or uric acid stones, and they also can be identified as a pitta-jashma. Then Vatajastu Shleshma Sanghatam Upagamya Yathoktam Parivardham Prapya Bastimukham Adhishtaya Sloto Nirunadi Tasya Mutra Pratigata Tivra Vedana Bhoti Tada Atyartam Pidyamanaha दन्तान् खादति नाभिं पीडयति मेढ्रं प्रमृह्णाति पायुं स्पृशति विशर्दते विदहति वातमूत्रपुरीषाणि कृच्छ्रेण चास्य मेहतो निस्सरन्ति अश्मेरि चात्र शाव परुष विषम खर कदम्बपुष्पवत् कण्टकाचिता भवति तान् वाटिकीमिति विद्यात्. Oxalate crystals, they are usually sharp, as we have seen there, sharp edges and somewhat cubicle-like shapes. And because of that sharp edges, and they tend to get accumulated, and which could be produced due to the causes of dietary hyperoxaluria or enteric, that's where the intestines are there, or idiopathic acid. Now, in this, the stones formed would have characteristically rough surface, and because of the rough surface, the stones, oxalate stones, are very hard in consistency, very hard, and the surface will be rough, having some these sickle-like appearances, pricks like pricking surfaces. That's exactly like Kadamba Pushpa. Kadamba Pushpa shape is a perfect description of the oxalate stones. Now, because of that sharp surface, oxalate stones, they tend to produce more of a hemorrhagic conditions, or they tend to injure the mucous membrane, hence there will be bleeding, and that blood gets deposited over the stones, and hence the oxalate stones will become usually blackish in color. Primarily, oxalate would not have black color. Primarily, oxalate would be having somewhat grayish color, but because the oxalate stones, they tend to have a increased chances of deposition of the blood pigments, it becomes black in color. So oxalate stones can be seen in both these colors, like either black or somewhat a grayish color, and the grayish color would have exactly the same shape of the Kadamba Pushpa and Kadamba as such. Now, or it could be shava. The color could be blackish, as in case of the blood pigment stone acid. And because the oxalate stones are small and having sharp surface, they would always produce more pain, and very frequently they present as the colics, because the stones, as the stones are formed, they tend to move out. During the movement, they tend to produce the acute colicky pain, and that's exactly the clinical description of Vata Jashmari, where there could be acute pain, and that acute pain is described by Sushruta in a very acute colic pain is very characteristic described by Sushruta, like Dantan Khadati, Nabhim Bidati, Medam Pramutati, Payum Sprashati, Vishardati, Vilahati. A patient having acute colic pain would be restless, but he would be feeling, he would not be able to pinpoint where the pain is. He will be pointing some different areas, and he tries to press, to squeeze, and so on, and roll on the bed. That's very characteristic, and that's exactly what Sushruta has described as. प्रायेण तिस्र अस्मरिः दिवास्वप्न समशन अध्यशन शीत स्निग्ध गुरु मधुर आहार प्रियत्वात् विशेषेण बालानां भवन्ति तेषामेव अल्पबस्तिकायत्वात् अनुपचित मांसत्वात् च बस्तेः सुखग्रहण आहरणाः भवन्ति. Now another controversial issue. Sushruta, according to Sushruta, incidence of the stones is more common in children. And the reason given by Sushruta is because they have more of kapakara ahara, and they tend to sleep more in the daytime, and they have lesser exercise. So possibility of kapha induced pathologies are more common in children. And according to Sushruta, the stones in the children is comparatively easier to be treated because the total volume of the urinary tract is lesser, and hence it can be. But if you look at the incidence of the stones now, gradually, the incidence of the stones is lesser in children. It's only in about 5% of the stones that you see the age below 18. Incidence of pediatric stone formations are very less. And the reason now is, or rather, majority of those children who have that comparatively lesser urinary the stones in the children, they have usually structural pathology, genetic structural pathology. So primarily in the practice, the rule is if you have a stone formation below the age of 10 in a child, there is a definite structural pathology in the urinary tract. So that would be some strict congenital or other way, and that needs to be treated. A simple management of the stone would not be enough. You need to assess that real cause for that abnormality, and that needs to be treated. Incidence of the stones now is increasing as per the age. Now, statistically, particularly in men, the incidence of the stone is very much increasing as per the age, and in the old age, the incidence is more common, and the cause supposed to be is due to the obstruction by the prostate, prostatic hypertrophy, inducing partial obstruction, and tendency for the stagnation of the urine is the major cause. Now, whatever Sushruta has said is the other way. Now, justification could be in olden days, Sushruta's period, the adults would always have samshodhana, the periodic samshodhana, and because they do that, that was a culture. And hence, because the adults they tend to have the periodic samshodhana, which may not be done in case of the children, maybe comparatively, the incidence of the stone in children might have been more than what you see in the adults. But in the present day situation, that culture of Shodhana is completely lost. Forget about the common men, even among the Ayurvedic graduates, that habit of Shodhana is not there, and they will have aversion for that, and hence the incidence of the stones could be increased. Maybe that could be one justification, and the other way would be it's also the dietary factors. Now, incidence of the stones as according to the age, again a data, universal data, the calcium oxalate stones are lesser in children compared to the adults, whereas phosphate stones are more common in children than the adults. That's what I told you, like because of the presence of a mechanical obstruction or structural pathology. That's all the other important issue. Uric acid stones also are lesser in children than the adults. This also shows the importance of the diet. So, whatever Sushruta has said may not be word by word true in the present day situation, but if you go into the principle, you can make out why it is so. Now, the food, as I told you, the oxalate contents, which are the oxalate containing food, and the substances, food substances which have lesser oxalate contents. And now, usually, whenever the person goes to a urologist, and the person is advised to avoid that high oxalate foods and low oxalate foods are usually advised. So, these are, I think, there is no need to repeat those issues. It's almost well known, and hence, and quite important is that this chocolate and cocoa and wheat bran, which is very frequently consumed by the people, uh, could be one of the very common cause for the stone formation. And the most important is water which and with lemon would be the best of the solution for the prevention or reduction of the oxalate content in the urine. Now, the another of the issue, controversial issue is the Shukrashmari mentioned by Sushila. Mahadam tu Shukrashmari Shukranimita bhavati Maitana Vighatat Atimaitanaatva Shukram Chalitam Anirgachat Vimargamanat Anila Abhitaha Sangrashya Metra Prashanayoh Antare Samharati Samhrityate Upashoshayati Sa Mutramargam Avranoti Mutrakritsam Vasvedram Prashanayoshcha Shvekum Apadayati पीडितमात्रे च तस्मिन्नेव प्रदेशे प्रविलयम् आपद्यते तां शुक्राश्मरीं विद्यात्. According to Sushruta, the Shukra Ashmari is produced as a result of crystallization of the semen, and the crystallization of the semen could be triggered due to absence of the sexual activity or excess of the sexual activity, and or maybe a retrograde ejaculation, when ejaculation occurs in a opposite direction. That's also considered to be a cause for the stone formation according to Sushruta. And the semen tends to dry up, and the dried semen would be a soft stone, and when it is squeezed it comes out and dissolves and then expelled out. This is the description of Shukrashmari in Sushruta. But practically, semen can never get crystallized or hardened, because it always, semen would have plenty of substances which help the semen to get remain liquefied substances. Hydrogen or as well as other liquefying substances are there in the semen. So once the semen is excreted out, it will get liquefied. So liquefaction is the physiological effect of expelled semen than really the other way. And hence, passage the semen getting obstructed in the urinary tract, resulting in a stone formation, is practically not possible. And the other way, whatever Sushil has mentioned, is the ejaculation, retrograde ejaculation, where the semen, instead of getting moving towards the distal side, if it gets ejaculated into the bladder, and very often it occurs due to abnormalities of the structure. Very often, it's a very common complication of the prostatectomy. Once the prostate is surgically handled, the it's a very common consequence that the semen may not be get expelled into the distal part of the urethra. Instead, it may be expelled into the bladder. And even in that condition, there could be only the presence of the sperms and the semen contents in the urine, and that too may not be a immediate cause for the stone formation. But later on, it can act as the semen can act as a needles, which can increase the these solvents in the urine, and hence it can be a stone formation. But that stone is not much different from the other white stones. So it acts as a needles, and the stone may be formed over there, but chances are very less. So hence, whether whatever that typical Shukrashmari with the typical description of mentioned as mentioned by Sushruta may not be seen as such. But you can see similar clinical presentation in the clinical conditions in case of the gonococcal urethritis. Patients who have a gonococcal urethritis, gonorrhea, a sexually transmitted disease, characteristically the pus formed in the gonococcal urethritis is very thick, and we call it as a gleat. And gleat is a thick whitish substance which may not be easily expelled out during that passage of the urine. But if you squeeze the penis, you may have the semi-solid substance expelled out, and probably Sushruta might have considered this as the Shukrashmari. Again, a big question mark, like, because you do not have the exact etiological factors, but the clinical presentations will be similar, where the patient will have some sexual activity, and after the sexual activity, there would be a squeezable soft substance, and which might have, and it has a similar color as that of the semen, and probably Sushruta might have considered this as the Shukrashmari, but a real Shukrashmari, a real stone formed due to the semen may not be possible. Or the other way which we can see could be the calcification of the seminal vesicles. Now there again it may not be a stone formation. A infective pathology involving the urinary tract can result in the calcification of the seminal vesicles, and in that condition the seminal vesicles would be opaque to the X-ray, and most of the times they would be asymptomatic. They would not produce any other clinical symptoms except that there could be a reduced ejaculation of the semen. the sperm count could be lesser, or the quality of the semen could be altered as a result of the seminal vesicle calcification, which is again a rare entity often seen in very old aged patients. Whether this has to be considered as Shukrashmari, controversial. It may not have the same clinical symptoms as that of the Shukrashmari, but a stone-like substance or stone-like pathology produced in the genital tract and related to the semen and semen formation could be the seminal vesicle. So that's one thing. Then the next part is about Sikata Meha or crystal urea. Now another of the controversy. According to Sushruta, the crystal urea is a Sharkara Sikatameha Basmakyo Ashmari Baikatam. Sikatameha or Sharkara, Mutra Sharkara, or Basma or Mutra Basma is all considered to be a complication of the Ashmari. ಅಶ್ಮರಿಯ ಶರ್ಕರಾಜ್ಞೆಯ ತುಲ್ಯ ವ್ಯಂಜನವೇದ ಪವನೆ ಅನುಗುಣೆ ಸಾತು ನಿರೇತಿ ಅಲ್ಪಾವಿಶೇಷತಃ ಸಾ ಭಿನ್ನಮೂರ್ತಿ ವಾತೇನ ಶರ್ಕರ ಇತ್ಯಭಿಧೀಯತೆ. Now crystals present in the urine could be of two categories. One, pavane anuguna sati nireti alpa. Yes, when the stones are not in big size, the smaller stones, they may be expelled out in the urine, or it could be Bhinamurti, it could be a broken piece of the stones and the crystals could be passed. Now, in the present day's practical situation, crystal urea or presence of the crystals in the urine is always considered to be a prodromal sign of the stone formation. Identification of the persons with the stone, risks of the stones can be made out by examination of the urine, and when you find these abnormal crystals, shapes of the crystals, again we have already referred to, again repetition of the same. It could be like a pointed hexagonal or the uric acid stones which are of irregular shape, straight stones which have that rectangular surfaces. So the stone crystals present in the urine, they are now considered to be one of the measures by which you can identify the patients who have a risk of the stone formation. So it's considered as a prodromal. Sushil has considered both the aspects of that. The crystal area could be a prodromal where the stones could be lesser in size and they may be expelled out in a person who has tendency for the stone formation, or it could be a consequence of the stones where the stones could be broken and hence the pieces of the stones may be expelled out. Now, that kind of a pathology is not generally mentioned in the textbooks now, that where the stones broken and then present in the crystal area. But breaking the stones is a part of the therapeutic approach. Lithotripsy, breaking the stones, is a part of the therapeutic approach where the pieces of the stones could be expelled out relatively easily. Then the other clinical symptoms could be Krupeda, Saktisadaram, Kukshishulam Javepatu, Trishna, Urdhogo Anila, Kashnam, Dorbalyam, Pandagatata, Arojaka, Avipako to Shakarate Bhavandita. Patients who have a metabolic abnormality and hence they tend to have the crystalluria of different sorts. The clinical symptoms could be any of these. Krupeda, there could be pain in the chest or abnormality in the epigastric area. Saktisadanam, lower limb, pain in the lower limb, abdominal pain, or excess of thirst, and tendency to have a retrograde movement of the abdomen in this movement of the peristalsis, retrograde peristaltic contents, carcinium, systemic abnormality like Daurbalyam, carcinium, that weakness, general emaciation as well as a relatively blacker color, or Pandagatrata, anemia, Arochika Vipako, digestive abnormalities also could be a clinical presentation of Sharkarata or crystalluria. Now, as I told you, the crystalluria could be most of the times a consequence of the metabolic abnormality, and these metabolic abnormalities can present with any of these clinical symptoms. And once it gets blocked in the urinary tract, the crystals get blocked in the urinary tract, they produce Mutramarga Pravurtasa Sakta Kuryadupatravan Dorbalyam Sadanam Kasham Kukshishulam Arotikam Pandupam Ushnavatam Jatustam Hritpidanam Vamim. Same clinical symptoms may be more pronounced when the crystals they tend to get blocked in the urinary tract and they produce the pain. And the pain would be more acute and the symptoms also would be more acute as such. Now, Sushruta has mentioned about the anatomy of the urinary tract, and the anatomy of the urinary tract mentioned by Sushruta is नाभिः पृष्ठ कटी मुष्क गुद वंशनशेफसाम् एकद्वारः तनुत्वकः मध्ये बस्तिः अधोमुखः बस्तिः बस्तिशिरश्चैव पौरुषं वृषणौ गुदः एकसम्बन्धिनो शेते गुदास्ति विवराश्रिताः अलाग्वा इव रूपेण शिरास्नायुपरिग्रहः मूत्राशयो मलाधारः प्राणायतनम् उत्तमम् पक्वाशे गताः तत्र नाड्यो मूत्रवहस्त्वयाः कल्पयन्ति सदा मूत्रं सरितः सागरं यथा सूक्ष्मत्वात् नोपलभ्यन्ते मुखानि आसां सहस्रशः नाडीभिः उपनीतस्य मूत्रस्य आमाशयान्तरात् जागृतः स्वपदश्चैव स निश्चिन्तेन पूर्यते आमुखात् सलिलेन्यः पार्श्वेभ्यः पूर्यते नमः घटो यथा तथा विद्धि बस्तिः मूत्रेण पूर्यते. Now the word basti is very often misunderstood. Most of the times basti is translated as a bladder. But in reality, if you look at the description of Sushruta, basti is not merely bladder. The basti is considered to be a structure which having a it is a alabu like shape where you will have a pedicle and it has only single opening. According to Sushruta, it has a single opening. Single opening can be made out if you consider the urinary collecting system. Urinary collecting system starts with the renal pelvis, the calyces, and then you have the ureter, then you have the bladder acid, the bladder acid. Of course, you will both these urinary pelvis together. So these form a closed structure, and there is only one opening, urethra. So, and that's the one of the important issue. Basti is a urinary collecting system starting from the urinary pelvis, which we now consider as the urological issue. Now, if you go to any modern hospital, you will always have some controversy between the nephrology and urology. When a patient goes there will be always a dispute like whether that patient has to be treated by a nephrologist or urologist. Now, the basic definition of the urology is when there is an abnormality related to the urinary collecting system that is in the scope of urology, whereas the other way is nephrology. Probably Sushruta also had exactly a similar view. So Ashmari is a urological issue, whereas Prameha is a nephrological issue. So Prameha we will discuss about that part in the later part as well. So that kind of a perception of the basti concept is absolutely necessary. Hence, the basti is not only the bladder, it could be the collecting system where the stones are very frequently formed. Then the mechanism of the urine formation according to Sushruta is again the because the urinary system, that collecting system is presented in a structure and you do not have a visible connection between the gastrointestinal tract. Sushruta has considered there are asankhya, innumerable, non-visible tubules which continue which throughout the day, jagrata swapadashari, both at the daytime or at night time when you sleep or so on, there is a continuous nishyandena, osmosis resulting in the leakage, transmission of the fluid, and these are what we call as nephrons. And Sushruta has mentioned the movement of the fluid from the gastrointestinal tract, which is a major source of the fluid supply, to the urinary tract through these invisible tracts. That structure of the kidney, and as we say, like nephrons, that's not mentioned. So, now when we say nephrons, we relate to only the kidney assets. The transmission of the nutrients from the gastrointestinal tract to the kidney through that system, the circulating system, is not mentioned as a part of the urinary system. Whereas Sushruta considers that whole system of transmission of the nutrients as well as the water content from the gastrointestinal tract to the collecting system as the invisible tubules which help in. So, virtually, there is no difference. The only difference is lesser details. Social has given lesser details and a comprehensive picture, whereas now you have more detail and more analytical approach. That's all the difference. So once we conceive in that manner, you don't have any controversy over issues. And the another example is about the osmosis, the fluid moving across semi-permeable openings or small openings. And example given by Sushruta is like a new pot kept in water. New pot kept in water will allow the water to flow across the pot. because of the small micropores, and these micropores are the same which regulated the osmosis. एवमेव प्रवेशेन वातपित्तं कफोऽव्या मूत्रयुक्तम् उपस्नेहात् प्रविश्य करुते अश्मरीं. So Nischanda and Upasneha, these are the two mechanisms. Nischanda is a free flow and Upasneha is a controlled flow. That's the selective absorption. So at some areas there is a selective absorption and some areas there is a passive process. So very briefly, simple, at the nephron, the tubules, the fluid would be a passive process where the concentration gradient allows. Whereas in the proximal convoluted tubule and distal convoluted tubule, there is a selective excretion and selective absorption. So Nischanda and Upasneha, these are the two mechanisms by which ultimately the urine is formed, and during the formation of the urine, all those doshas also can be accumulated and hence the stone could be formed. Now about the theory of the stone formation, Sushruta has given a higher importance to the nearest theory. Apsu swachhaswapi yatha nishiktashname gate कालांतरेण पंकस्यात् अश्मरी संभवस्तदा संहन्ति आपो यदा दिव्याः मार्तो अग्निष्टवेद्युतः तद्वत् बलासंबस्तिस्थम् ऊष्मा संहन्ति सानिलः. The two theories, the needles formation, where the condensation of the crystals, insoluble substances, can result in the stones. That's the first example. Like a water kept in a new pot, gradually we'll see that crystallization, condensation, resulting in some hard stones or hard material, or a drying up of the water content. Marko Agnishtvajudah, reduction of the water content, where it becomes dried up, also result in the stone formation. And in both the ways, according to Sushruta, the kapha is the major source of the stones formation. Whereas in Charaka, the major stress is given only to the hyper concentration theory, where the urine has become dried up. विशोषयेतु बस्तिगतं सशुक्रं मूत्रं सपित्तं पवनं कफं वा यदा तदा अश्मयुपजायते सक्रमेण पित्तेषु रोचना भोः. According to Charaka, is compared to the Gorochana, where Pitta is the major causes. Of course, this difference doesn't make very huge issue, but according to Sushruta, Ashmari is a Kafaja Vyadi. Now, the process of the condensation is exactly the same, that where initially you will have the small crystals over the needles, and then gradually it becomes a bigger stone as such. Of course, the cuts to summarize, the causes for the stones are mainly either it could be the idiopathic structural disorders related to the fluid, medicines, environmental, and urinary tract obstructions, dietary factors. So multiple factors put together can result in the stone formation, and the theories are of the same, either the formation of a nucleus or needles, or it could be the condensation due to hypersaturation, supersaturation, or the other factors. Now, Sushruta has added one more, the stagnation theory. The stagnation theory also is quite important. Marute pragune bastau mutram samyak pravartati vikaraha vividhaschapi pratilome bhavanti. Majority of the abnormalities of the urinary tract occur only when there is a stagnation of the urine. As long as the urinary flow is normal, there may not be any pathology. Now, stagnation of the urine may not be only a clinical sign. Patients many times may not know about it, but stagnation now can be measured by a uroflowmetry. Uroflowmetry is a very useful investigation to identify subclinical abnormality of the urinary flow. And subclinical abnormality of the urinary flow could be of any sorts. Normal urinary flow would be once the patient starts urine, it will be expelled out with a high force and then results in. This is normal. Abnormalities are of any of these categories. So uroflowmetry is one of the important tools to identify that subclinical abnormalities of urinary flow. And of course, in a case of prostatic obstruction, this is the typical appearance. You will have a peak and then gradual small waves. And a slow progress, time taken for the urinary flow would be lesser. Now, according to Sushruta, this is a stagnated abnormality of the urine or urinary excretion abnormality is a cause for any of the diseases, Mutragata, Prameha, etc. But whereas now we do not have this kind of a linkage. We know that there could be abnormality of the urinary flow and it can be measured, but it's often linked to only the prostatic urethral obstructions, or it could be related to the possibility of the stone formation. Beyond that, being a cause for the other reasons are not known. Maybe that could be one of the areas of research, like patients who have this abnormality of the urinary flow and whether they would be present in systemic disorders like Mutraghata, Prameha, Shukradosha, etc. Whether this is possible or not, this is a really subject of interest, maybe possibly, but at present we do not have that kind of a linkage. Now, of course, to summarize, the risk factors for the stone formation, low urine formation, hypercalcemia, it's the same thing, repetition. And of course, the treatment part we will discuss when we discuss about the chikitsa. इति सुश्रुत संहितायां निदानस्थाने अश्मरी निदानं नाम तृतीयोऽध्यायः. With this we conclude today. If there are any questions, I'll try to answer and then wind up. Right? There are no questions. Okay, many of them wish a happy birthday. Thank you. Thank you all for wishing. Right.
Happy birthday, sir.
Thank you.
Happy
Thank
birthday,
you.
sir.